All right, hi everyone. Thank you for coming to tonight's Grand Rounds with Dr. Uber. If anyone has any questions throughout the talk, please just type them into the Q&A box at the bottom of your screens and we'll get to them at the end. Now, I'd just like to introduce our speaker for tonight. Dr. Lucy Uber is board certified in pediatrics and obesity medicine. She was born and raised in Los Angeles, went to medical school at Tel Aviv University Sackler School of Medicine, and completed residency in pediatrics at Einstein-Jacobi Medical Center. She's the owner of Burbank Pediatrics. Her passion is treating both children and adults for obesity and helping them change the trajectory of their lives for a healthier future. And now the floor is yours, Dr. Uber.
Hello. Thank you for having me. I'm super excited to give this talk. This is a subject that I'm really passionate about and that I love doing and practicing every single day. So please feel free to ask questions. I'll try to answer them if I can. It is a pretty new field in medicine, so things are always changing and there's constantly updates. All right, so I have nothing to disclose. So during this talk, we'll be talking about what the definition of obesity is, the epidemiology, the pathophysiology, treatment, and clinical evaluation. So what is obesity? Obesity is defined by the Obesity Medicine Association as a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. That's quite a mouthful, but we'll get right into it. So, epidemiology. So worldwide, the prevalence of obesity nearly tripled between 1975 and 2016. It's now recognized as one of the most important public health problems facing the world today. According to the WHO, and this was in 2016, there were around 2 billion adults currently living with overweight, of which 650 million were considered to be affected by obesity, which is a BMI of over 30. So that's about 39% of adults aged over 18 living with overweight and 13% living with obesity. Now, I would assume those numbers are quite larger than that, given the COVID pandemic and the massive amounts of obesity that we've seen as a result of the pandemic. So by 2020, they estimated that 770 million adults globally were affected by obesity, and it's expected to exceed 1 billion by 2030. We're on that trajectory right now. So by 2030, about half of Americans will have obesity, which is quite an astonishing number. Just looking at the map here, this is what we are expecting to see in the very near future. We're seeing a lot of it already. You can see none of these areas have any green or yellow. So we're looking at pretty much 40 to 49% throughout, and in some states, especially the Midwest, 50 to 59% by 2030. So this is a CDC map of obesity from 2022. You can see over here in California, we are one of the few states with 25% to less than 30, same with New York. And a couple other states throughout, but most of the states we're seeing here are around 30, 35, 40, and in some cases already 40 to 45% over in Kentucky and West Virginia. So there's different ways to classify obesity. This is probably the most familiar for most people. This is the WHO classification, and this is the BMI. So you have your underweight, which is less than 18.5, normal range, which is 18.5 to 24.9. And after that, pretty much everything is overweight to obese. So over 25 BMI is overweight to 29.9. Obese is greater than 30. And then after 30, you have obesity classified into class 1, 2, and 3, with 3 being severe obesity, and that's a BMI of over 40. The CDC classifies BMI a little bit differently, but mostly the same. So you have your overweight at 25 to 29.9, your obese at 30 to 34.9, and extremely obese at greater than 35. This is a little bit more of a helpful tool. This is the Edmonton Obesity Staging System, and this is more helpful in clinical practice. So this is a little more descriptive, and it gets into the medical, mental, and functional obesity subtypes. So we'll go directly into that, but you can see kind of going across. You have stage 0 to stage 4, and we'll go directly into stage 0. So this is a person who has no sign of obesity-related risk factors and no physical symptoms, psychological symptoms, or functional limitations. So an example of this would be a physically active female with a BMI of 32. And so she has no self-esteem issues, no medical problems really, and no functional limitations, but her BMI is considered obese. You move into EOSS stage 1. This is a patient that has obesity-related subclinical factors. So this would be something like a borderline hypertension, impaired fasting glucose, elevated liver enzymes, or, and you don't have to have all of these, it's or mild physical symptoms. So a patient that's currently not requiring medical treatment for comorbidities, but they may be having something like occasional aches, pains, maybe some knee pain, back pain, fatigue, dyspnea on moderate exertion, or they can maybe have some psychological symptoms or mild impairment of their well-being, but their quality of life hasn't yet been impacted. So one example of this would be a 38-year-old female with a BMI of 59.2, borderline hypertension, mild low back pain and knee pain, but doesn't require any medical intervention. So at this point, we're not having to prescribe any meds, though her BMI is quite high, and likely will be having those comorbidities in the future. Stage 2, this patient has established obesity-related comorbidities that require medical intervention. So that's the difference between stage 1 and stage 2. So here you have hypertension, type 2 diabetes, sleep apnea, PCOS, reflux, and again, it's or they can have just moderate obesity-related psychological symptoms like depression or an eating disorder, anxiety disorder, or a moderate functional limitation in their daily activities. So here their quality of life is starting to be impacted. And this, an example, would be a 32-year-old male, BMI of 36. He has primary hypertension and obstructive sleep apnea. Stage 3, this is a patient who now has significant obesity-related end organ damage. So they now have either a myocardial infarction, heart failure, diabetic complications, or incapacitating osteoarthritis. Or they may have significant obesity-related psychological symptoms like major depression, suicidal ideation, or they may have functional limitations that are severe, like they're unable to work or complete routine activities or have reduced mobility. They do have significant quality of life that is impacted. In this example, we have a 49-year-old female, BMI of 67, diagnosed with sleep apnea, cardiovascular disease, GERD, and had a stroke. Her mobility is significantly limited because of her osteoarthritis and gout. In stage 4, this is severe, potentially end-stage obesity. So they have obesity-related comorbidities or severely disabling psychological symptoms or severe functional limitations. So for this, you may have a 45-year-old woman, BMI of 54. She's in a wheelchair because of her arthritis. She has severe hyperpnea and anxiety disorder. So this person is probably not really leaving the house and probably has needs for a lot of medical intervention at this time. Pathophysiology. So this is a very, very simplified slide for the factors that influence obesity. As you all probably know by now, obesity is multifactorial. It's a combination of genetics, environment, behavior, as well as many other things, but it leads to an increase of the things you see on the screen, but many, many other complications. So the most common concerning conditions would be heart disease, type 2 diabetes, cancer, high blood pressure, joint disorders, and this is just a very limited list. I just wanted to put this in here to kind of stress how our genetics really do have an influence, especially epigenetics, which we're learning a lot about right now. So this is just one study that showed maternal obesity showed that there is a 264% increase in the odds of child obesity when mothers have obesity before conception. So even before the mother is pregnant with the future child, if she is obese, she will have a 264% increase of passing on obesity to her child. And so that just means we really need to focus on weight loss before a woman is thinking of getting pregnant, not after, not during. It really has to come before conception. Just another aside for breastfeeding, another evidence-based way to reduce obesity is breastfeeding. For those who can, of course, breastfeeding showed a 15 to 30% reduction in adolescent and adult obesity rates if breastfeeding occurred in infancy as opposed to no breastfeeding. So breastfed siblings weighed 14 pounds less than formula-fed siblings in a sibling difference model study. And each month is associated with a 4% reduction in the risk of obesity. Breastfed infants were more likely to self-regulate the intake volume, which affects the adult weight gain. And infants given breast milk in bottles do not learn to self-regulate as well as infants that are breastfed. So it's really the act of feeding at the breast. So this is not to scare you, but the pathophysiology of obesity is very complex, and it's on a multi-organ level where you have a combination of gut hormones, brain stem hormones, and peripheral hormones and signals that are interacting. And some of these are appetite stimulatory and some are inhibitory. And as you can see on the screen, you really just have one appetite stimulating hormone, and yet you have all these other hormones that are responsible for inhibition. So that just kind of shows how powerful our hunger hormone is, that it takes all these other neurons and hormones to try to counterbalance that. So really our main hunger hormone here is ghrelin, and our main satiety hormone is leptin, which you've probably heard about. So leptin, insulin, adiponectin, PYY, oxyntomodulin, PP, GLP-1, CCK, these all act to promote satiety, whereas ghrelin opposes that and acts to promote hunger. This is just a small diagram kind of elucidating that a little bit better. Ghrelin is secreted from the fundus of the stomach, and it leads to increased hunger, which then leads to increased food intake. Whereas CCK leads to increased bile production, pancreatic and gastric secretions. PP leads to decreased gastric emptying and pancreatic secretions. GLP-1, this one is important. I'll mention it a bit later. This slows gastric emptying. And the others are all also influencing digestion and appetite regulation. Again, just same, these are the orexigenic and anorexigenic pathways. So again, you see ghrelin here at the top. So this is our orexigenic or hunger pathway. So ghrelin will activate NPY, AGRP neurons in the hypothalamus, which have downstream effects of causing hunger, which are opposed by the anorexigenic pathway, which is modulated by leptin. So that then will also inhibit this other pathway and leads to downstream effects of satiety. Leptin, again, just again, showing how kind of complex this whole pathway is. This is just the tip of the iceberg, but when you have weight loss, leptin actually decreases. And so you actually are hungrier when you lose weight. So that leads to increased food intake and other biological mechanisms that are trying to restore the energy balance and get that weight back. So now you have a decrease in energy expenditure and an increase in parasympathetic tone. Whereas with weight gain, you have an increase in leptin. And then the response to this obesity is decreased food intake and an increase in energy expenditure and increased in sympathetic tone, which is probably why we see the hypertension and other cardiovascular downstream effects. So ghrelin, we're learning a lot about ghrelin right now, and that it's not really just a hunger hormone. It has a lot of other impacts throughout the body, such as in the hypothalamus, what we know, it increases appetite, increases food intake. But in the non-hypothalamic brain areas, it is responsible for reward behavior, olfaction, learning and memory, sleep-wake. And in the sympathetic nervous system, it causes decreased activity. And then the others here, just one thing to point out is it increases insulin sensitivity and glucose metabolism, and in the intestine, increased motility. So lots of effects from ghrelin that are kind of shown here. And then this again is the same pathway, just kind of at the level of the organs, and then in the arcuate nucleus of the hypothalamus, and then the downstream effects relating to food intake. So you really have two opposing pathways, and they're constantly working against each other. And then that leads me to what is sick fat. So this term sick fat is how we discuss obesity. So adiposopathy is a pathogenic adipose tissue that is promoted by a positive caloric balance and a sedentary lifestyle in genetically and environmentally susceptible patients. It anatomically manifests as adipocyte hypertrophy, visceral adipose tissue accumulation, and ectopic fat deposition, and physiologically results in diverse metabolic and immune consequences leading to clinical metabolic disease. So what this is basically saying is that you have fat that is disrupted. It's not normal fat. It is sick. And what it manifests as is as hypertrophied fat cells. So you have enlarged fat cells, And because of these enlarged fat cells and the hyperplasia of fat cells, you get adipose tissue accumulation that then deposits into your viscera. So along your heart, along your liver, in your viscera. And downstream, you have these immune consequences and metabolic disease. So how does this kind of look? You end up with excess food intake and a low energy expenditure. So you accumulate fat, which is these adipocytes, which then hypertrophy, become enlarged, and they release pro-inflammatory factors such as adipocytokines and cause lipotoxicity. And all of that is correlated with several subtypes of cancers, which we'll get into later, as well as non-alcoholic fatty liver, cardiovascular disease, and metabolic disease. So mostly we'll talk about obesity in terms of hypertrophy, but you can also have hyperplasia. So this is when stem cells increase, and then you just get more adipocytes from this hyperplasia. Whereas hypertrophy is an increase in the adipose tissue mass. You're more likely to see hyperplasia in a child or a younger person, and hypertrophy is typically associated with older adults with obesity. So what I thought was super fascinating that I've learned in the past few years is this beiging of the fat. So we once thought that we only had the brown fat that we started with as babies. And then everything else was kind of white fat, and that's what we had, and that's what you get. But we're now learning that we can actually promote brown adipocytes in what's called beiging of the fat. And so you can actually increase the uncoupling proteins in the fat cells and increase, therefore, the brown adipocytes through different mechanisms, one of them being exercise. So obesity in general, when we look at its impact, if you look at the physiological and anatomic alterations, it really impacts everything from head to toe, starting with obstructive sleep apnea, to the kidneys, glomerular function, adrenal function, and eventually sympathetic activity being increased. And that eventually affects the vasculature with arterial stiffness and endothelial dysfunction. You have metabolic dysfunction, hypertension and vasoconstriction, and renal dysfunction, as well as left ventricular hypertrophy. And all of these things are related and have interplays. And eventually, I think most people that suffer from severe obesity will face one or more of these consequences. There's a genetic predisposition, and then there's stress and anxiety, which definitely can impact the physical and biological system. But with a genetic predisposition and the right stimuli, you can promote this dysfunction. So one example is the mechanism of this kidney damage in obesity. So in a non-obese state, you have a healthy podocyte and capillary in the glomeruli. But in the obese state, you have increased capillary wall tension and increased capillary diameter. So you have leakage of these proteins and decreased podocyte density. And then you end up with impaired autoregulation and kidney disease. Cancers associated with overweight and obesity. There are many, And these are known to be associated specifically with obesity, independent of any other risk factors. So, and everything from thyroid disease to adenocarcinoma of the esophagus, endometrial cancer, ovarian cancer, and colon and rectal cancer. We're all familiar with these consequences of insulin resistance and central obesity. So this is our diabetes, cholesterol, coronary artery disease, PCOS, hypertension, infertility. Other potential effects from obesity. So our immune system is dysregulated with obesity. So because of the excess of adipose cells, there is impaired crosstalk with the immune system, and there's an increase in pro-inflammatory macrophages, eventually dysregulated cytokine production. So just having obesity impairs the immune system. Hypovitaminosis D also causes an impairment of the immune response. As we know, vitamin D is necessary for immune function. So having excess fat cells impairs the fat absorption of the vitamin D. And then respiratory issues. Just having excess weight on top of the chest causes decreased pulmonary volumes, decreased compliance, VQ mismatch, and respiratory muscle inefficiency. Obviously, critical care limitations if you're trying to intubate a person with obesity. And then skin, soft tissues, we have disrupted micro and macro circulation, delayed wound healing, lymphedema, other comorbidities we've already touched a lot about. And then pharmacological issues, something to think about is we have limited data on the right dosing of antimicrobials in obesity. So we don't really know if having this excess weight is going to impair the delivery of the drugs, and if we need to be changing the doses according to the weight. We don't really have enough data for that. We also have altered protein binding and metabolism and volume of distribution of the antimicrobials. Same idea. So getting into treatments. So this is kind of, I took this slide from Angela Fitch, who is one of the leaders in obesity medicine. And this is the treatment pyramid. So the intensity increases as obesity increases. So we start with the bottom tier here, which is multi-component intensive behavioral intervention. And this is a goal of 2 to 5% weight loss. And then next we would move on to prescriptive nutritional intervention. So this would be your meal replacements, your intermittent fasting, or other specific diets with a goal of 5 to 10% weight loss. Right in the middle here, we're getting into patients that have a BMI of 30 or a BMI of 27 with a comorbidity. And many of the medications that we see have these requirements. So you cannot put somebody on a semaglutide or these other GLP-1 meds without them having these. So this is with a hope to achieve 5 to 20% weight loss. Then you have your endoscopic procedures. This image shows a balloon, but really no one's doing that anymore, or at least I wouldn't recommend going to someone who does that. And then here we have surgery. So this is with a BMI of 35 with a comorbidity or a BMI of 40 without. And with these, you're expecting a 20 to 40% weight loss. So everything depends on what kind of a practice you're in. For example, I practice everything from this green box below. I'm not a surgeon, so I don't do surgery. So with my patients, I focus on these 3 tiers, whereas a surgeon might want to start here, depending on their, the patient that's in front of them. Usually the patient will have probably tried something here before going to here. I'm going to touch briefly on pediatric weight loss. This is probably one of the only few slides I have here. There's a whole separate, this is a whole separate topic, and I could talk about this a lot more, but we'll just touch on it. So pediatric weight loss is definitely a different animal. So you're not trying to achieve the same effects as you are with adults. So if you can really think about weight loss in children as young as 2. So from 2 to 5 years, we consider 85 to 94th percentile overweight and 94th and above with having obesity. So really you want to maintain weight until the BMI is less than the 85th percentile. So really you're thinking about weight maintenance in this age group. So really just not trying to gain weight. But if they are losing, they shouldn't really lose more than 1 pound per month. 6 to 11-year-olds. So same, mostly weight maintenance. If the loss is, it should not be more than 2 pounds per week. So that's kind of the same as adults. And in greater than 12-year-olds, weight loss again until less than the 85th percentile and no more than 2 pounds per week. This is a refresher, just so we remember our categories here. So I'm going to start with the first tier of the pyramid, and this is kind of my bread and butter. I really believe in lifestyle modification, not that I don't believe in medical management as well. I think there's a place for that, but from my experience, I really think that the people who've been most successful have done so with a lot of work in this area. So we start with diet and nutrition, and I usually don't talk about it as a diet. I talk about it as this is just how we're going to be eating from now on. And this is how we need to eat to be healthy, functioning humans that will live long lives. So really, we have to think about a calorie goal. Reducing portion sizes, limiting processed foods, increasing fruits and vegetables, all the basic things that we all probably should be doing. Physical activity, which includes both aerobic exercise and strength training. And then behavior modification. So setting realistic goals. So if somebody says, they come to you when they're 50 years old and they weigh 250 pounds and they tell you, well, when I was 16, I weighed 130 and I want to get to that again. I think we have to really try to hone in on that and see what's realistic and what's necessary. And then maintaining a food and exercise diary, as well as practicing portion control. So I like to use MyFitnessPal a lot. And I really find that the people who commit to using it, it's an app. It's an app that you can download for free, and you really shouldn't have to pay for it. And you can track everything in there, including macronutrients and calories. And I think it really helps with accountability as well as learning, because a lot of people really don't have a basic understanding of calories and carbohydrates and fats and things like that. And I think it's helpful for them to educate themselves when they do that. So I find that a lot of patients are resistant to starting physical activity, especially if they've gotten to a point where they're at a BMI of 35 plus and they're really not active. But I make them promise that at some point they will become physically active, because I truly believe that's the long-term only solution to maintaining weight loss. It improves body composition and prevents muscle loss during weight loss. So whenever you lose weight, you're not just losing fat cells, you're also losing muscle. So it's really important to build back the muscle while you are losing, especially because muscle cells are more active at a basal metabolic rate level. So they have increased density of mitochondria. So when you have increased physical activity, you improve adipocyte function. So that was kind of our browning of the white adipose tissue. And exercise decreases the adipocyte size and increases mitochondrial activity. There was a study on men that showed resistance training reverses the obesity-induced undesirable changes in the blood levels of hormones such as testosterone, growth hormone, insulin, catecholamines, leptin, cortisol, adiponectin, ghrelin, and inflammatory cytokines. So I'm sure there are endless studies showing this. So we really do know that exercise is crucial. It's not really optional in my opinion. So immune function, physical activity, so moderate intensity physical exercises stimulate cellular immunity. Muscle contraction leads to transient increases in pro-inflammatory IL-6, followed by increases in anti-inflammatory IL-10 and TGF-beta, which inhibits pro-inflammatory cytokines. IL-10 is also associated with enhanced insulin sensitivity and glycemic control. And the anti-inflammatory effects of exercise are reversed within 48 hours. So you really do need to be exercising frequently, not once every week. And so this is evidence that this exercise is actually helpful with immunity. So you have the initial inflammatory process, which is when you kind of break muscle to build muscle, and eventually you end up with a pro-immune response. So getting into prescriptive diets. So I wouldn't call this necessarily a prescriptive diet, but I would tell certain groups of people to maybe have a vegetarian diet. I'm not a huge fan of vegan diets. I find them to be really hard to have a complete diet to attain, all the vitamins and minerals without overeating processed foods. There are people who are capable of doing it, but I think for majority of Americans, this is probably not the right move. But if they are at risk of cardiovascular disease, then something like a vegetarian or a Mediterranean diet might be a good choice for them. So protein is really one of my biggest bullet points. You want to make sure that your patients are always getting enough protein. And I focus on protein and I build out the meals around that. So for vegans, they don't have any animal products. So they have risks of B12, iron, zinc, calcium, vitamin D, and omega-3 deficiencies. So it's important that if you do have vegans in your practice, that they are supplementing with B12, vitamin D, and omega at least. And these omegas are super important, especially if they're not eating any fish for many reasons, but they are also anti-inflammatory. So they help with reducing the risk of cardiometabolic disease. Decreased LDL, decreased diabetes risk and improved glycemic control are some of the benefits of a vegetarian or vegan diet. Mediterranean diet. It's a moderate fat diet. So it contains about 35 to 40% fat. It's high in fat and high in omega-3s. The extra virgin olive oil is the primary fat that Mediterranean diets are composed of. And it also includes whole grains, fruits, veggies, legumes, nuts, and monounsaturated oils like olive oil, avocados. There's fish and seafood and moderate alcohol, usually red wine. Limited poultry, dairy, red meat is infrequent. So there was the PREDI-MED study, which showed that there was a 30% lower risk of a first cardiovascular event on the Mediterranean diet and a 40% lower risk of developing type 2 diabetes. There was another study that showed there was a 50 to 70% lower risk of recurrent cardiac disease. So meal replacements. This is a very specific type of diet, and I wouldn't recommend this to most people. Meal replacements are usually used for people who need to attain a significant degree of weight loss. And there's different ways to do it. There's two types specifically. One is the VLCD, which is the very low calorie, and the LCD, which is low calorie. And you can also use meal replacements, which is kind of what I do sometimes for patients that are incorporating that into their diet. So for example, maybe breakfast, they'll have a protein shake, and then for lunch and dinner, they'll eat a balanced meal, or they'll do a protein shake for breakfast and dinner, and then have a big lunch. And there's different ways of doing this. But this is just one of the ways of doing it. I'm not a huge fan of total meal replacements, but if somebody is trying to achieve a significant weight loss with, in order to get bariatric surgery or something, that could be something that would be helpful. I just haven't found it to be the most helpful with my patients, but that doesn't mean there's not a place for it. So an overview of the very low calorie diet. It's designed to promote nutritional ketosis. And in turn, when you have high ketones in the blood, you have reduced hunger. But that typically takes, I would say, up to 5 days. So really, you're dealing with a lot of hunger. Some people say after 24 hours, it's better. Some people say after a couple days, it's better. But for a lot of people, it could take up to 5 days. So really, until they're in ketosis, their hunger is still very much present. And so how they do the VLCD is you have 3 to 4 meals per day. And in each of these meals, you have 500 to 800, all of the meals together, 500 to 800 kcals per day, coming from 45 to 60 grams of carbohydrates and 50 to 60 grams of protein. What is good about this, if it's medically supervised, is that it meets 100% daily requirements for vitamins, minerals, trace elements, and essential fatty acids. So these are usually obtained through a specific company that designs these protein shakes or meals to be all encompassing of all the nutrients that a person would need in that amount of calories, because otherwise trying to get all of your nutrients from 500 to 800 calories on your own is next to impossible. So how does this work? So carbohydrate is the preferred energy source normally. With limited carbohydrate intake, you promote gluconeogenesis, and ketone bodies become the energy for the brain and the heart. So 3 days of the appetite, I guess, on average is the increase, and then the ketones will suppress the appetite. Eventually, you'll use free fatty acids as energy in skeletal muscle. And this is our beloved pathway, eventually you use these ketone bodies in the brain. So that's true ketosis. So who is suitable for this? So this is really for adults with a BMI of above 30 or the 27 with medical complications. So for example, where rapid weight loss is desired, so having bariatric surgery or post-operatively because they're having difficulty with eating or because you want to maximize that weight loss. So these are the contraindications: pregnancy, older age, I would say older than 65, or recent MI, unstable angina, organ failure, severe psychological disturbance. So anyone with an eating disorder, I would not do this. Alcohol or drug abuse would not do this. And then obviously, if somebody has other comorbidities, you should really be careful. So that's your type 1 diabetics, your gout, renal disease. Potential adverse events and complications. So these are severe nutrient, caloric deficient diets. So not nutrient deficient, but with this caloric deficiency, you can see things like dry mouth constipation, hypotension, dizziness, menstrual irregularities, hair loss. Those are both early and late. And then eventually you really do have to start decreasing your exercise. You can even have acute psychosis. So this is definitely, it's diet, but it's definitely a medical intervention. So it needs to be closely monitored. So pharmacotherapy, so this is what everyone's probably most excited about, what everyone's been talking about lately. There's a lot of anti-obesity medicines. I want you to kind of ignore this whole section because I am not going to be giving you any recommendations in terms of dosing, as every patient is different. But these are kind of the basic dosing. And these are the mechanisms of action. So phentermine is an older drug. It's been around for decades, and we know that it's safe. So this is really a sympathomimetic. It's an appetite suppressant. Orlistat works in the gut as a lipase inhibitor. There's a combination of phentermine and topiramate, which is used with some people that have combinations of appetite who need the appetite suppressant effect. And you can also think about using meds sometimes as a dual for dual effects. For example, in someone that has migraines, you might want to speak with their neurologist and consider using topiramate with the phentermine. Liraglutide, and semaglutide. These are the GLP-1 agonists. These are the injectable anti-obesity meds that have been all the rage and are quite effective. So they work by being titrated up over the course of several months, and they work on the gut and the brain. So for adolescents with obesity, we have a long list of drugs as well. A lot of the same ones. All of them have different indications, and I'm not going to get too much into it since I think we don't have too much time. But there are some that are new to market, and some that have been around for a long time. And they all work on appetite regulation for the most part, except for orlistat, which reduces fat absorption. So this really just allows for fat to kind of come in and come right out. One thing I want to stress is that a lot of the medications that we prescribe to patients can actually cause weight gain. So whenever you put a patient on a medication, and that patient is at risk for obesity or already has obesity, try to maybe give them a medication that will either be weight neutral or will potentially help them lose weight. Surgical options, I'm just going to briefly touch on this because this is not my specialty, but there are different types of surgeries for weight loss. The lap band is not really being used. There were a lot of complications. So these are kind of the more commonly done surgeries. And the vertical sleeve, I think is super interesting because, as you can see here, they're removing the gastric fundus. And initially, when they started doing this surgery, they thought that by reducing the volume of the stomach, people would just not have as much room for food and therefore wouldn't really eat as much. But what they found was that one of the reasons at least, that people were losing so much weight is because ghrelin, that hunger hormone, is actually secreted from the fundus here. And so when they took out the fundus, people just didn't have that hunger hormone released as much. So again, just kind of the same. Other things to consider is just micronutrient deficiencies post-bariatric surgery. If you have patients in clinic or that you see that have had bariatric surgery, they're at risk for these deficiencies. B12 deficiency, just, special populations, patients on metformin, they probably need to be supplemented, as well as vegans and children with obesity. So I want to just talk a little bit about how I manage these patients. So when I have a new patient come into my office and we're starting to get into weight management, the first visit is quite long and comprehensive. I spend about an hour. And the first thing that we do is we take vitals, blood pressure, BMI, weight, obviously. We take a waist circumference, which is measured from the top of the iliac crest, and a neck circumference. I ask them about their past medical history, starting from birth. For example, was their mom diabetic? Did their mom have gestational diabetes or preeclampsia, any past surgical history, any family history of obesity or other metabolic diseases, any medications this patient might be on, allergies, if they drink alcohol or use cigarettes or have other drug use, if they have any history of depression or bipolar. And then for obesity history, I really want to know what's their highest weight. Oftentimes it's the weight they are currently when they come in. And then what other diets have they tried in the past? What's their physical activity? Food recall from the past 24 hours. And what is their work like? What do they do? Are they sedentary? Are they active? Are they lifting things? And how is their sleep? Are they snoring? Do they have any apneas? I also give them surveys. They do the binge eating disorder questionnaire, the nighttime eating syndrome questionnaire, and the PHQ-9 for depression. And then a physical exam. So I'm looking for any possible signs of other diseases. So hirsutism, looking for maybe PCOS, moon phases, looking for Cushing's, looking at their eyebrows. Do they have possible hypothyroidism? And then just a general physical exam, looking really for any other stigmata, like any purplish striata, or any hepatosplenomegaly, anything really. And then follow-ups are usually at 2 weeks. We go over labs and go over a food log in MyFitnessPal. And we do follow-ups every 2 weeks until they're really on this autopilot by themselves. Once they're consistent in their routines, then maybe a monthly follow-up. And then depending on what medication adjustments are being made, they might need more frequent follow-ups. And then I encourage them to do weekly self-weigh-ins. So obesity is a chronic disease, so it is relapsing and remitting. Most people will gain and lose throughout their life. So long-term follow-up is necessary. Each patient has a unique phenotype. There's no one way to treat obesity, and what works for one patient may not work for another. There's no magic cure. So even if you put someone on GLP-1 or other anti-obesity medication, it is a lifelong disease. So you can't just expect that you'll lose some weight and then you stop the medication, because at that point, if you haven't made the other lifestyle changes, you'll gain that weight back. And then in practice, in general practice, help patients where you can. So try to switch obesogenic meds, whether it's anti-epileptics, antipsychotics, or cardiac meds, to weight neutral meds, and take care of yourself first. Patients need you to model the behavior. So make sure you're doing all the good things too. All right. Thank you.
Thank you so much for speaking tonight. I really appreciated the detail and the pathophysiology. It was an excellent refresher.
Awesome.
And this is such an important topic also. We're just going to open the floor for questions, so please feel free to type them into the Q&A box at the bottom of your screens. I do see there is one question.
Yes.
What was the app to track your own weight?
So MyFitnessPal, it's an app that you can track really everything from breakfast to dinner, and super useful.
Thank you.
Yeah.
We'll stay on for about a minute. If anyone has any questions, feel free to type them in. All right, thank you so much for your lecture. It was very informative.
Thanks for having me. I'm available at these places if anyone has any questions or is interested in getting into obesity medicine.
Great, thank you. And thank you to everyone for joining us tonight, and have a good night.
Good night. Bye.